We're going to talk today about HIV, STD safer skills groups for women in methadone maintenance or psychosocial outpatient treatment. This work was called Protocol 19 in the NIDA National Drug Abuse Treatment Clinical Trials Network. I am Susan Tross, and I'm the principal investigator of this work. This work is the sister study of a very similar study by Dr. Don Carlson at the University of Washington, which worked with men. This work is supported by a grant from the National Institute on Drug Abuse to Dr. Edward Nunes at New York State Psychiatric Institute at Columbia University Medical Center in New York. Now, why were we concerned about HIV risk in women? Because the HIV epidemic in the United States moved us there. Heterosexual women are among the fastest growing subgroups of people with AIDS in the United States, accounting for roughly 20% of new infection cases. Heterosexual transmission accounts for 84% of new infections among women, followed next by injection drug use at 15%. Now, among women who have been infected by heterosexual transmission, partner risk factors most especially include partners that are injection drug users. When women are positive and are asked what do they think the risk factor in their partner was, they most frequently identify injection drug use. But many, many more heterosexual transmission cases are probably accounted for in part by drug use. Only the women who are studied report that they don't know the risk factor of their partner. Now, sadly, HIV is concentrated among adult and adolescent women of color, so 67% of women with AIDS are African American, 18% white, and 13% Latina. Along with HIV, high-risk sexual behavior can also bring STDs to women, and rates can be very high. As an illustration, at the bottom of this slide, you can see that among family planning clinics, chlamydia rates are between 2.4 and 11.3%. So HIV and STD sexual risk behavior is an important factor among all the women that we see, no matter what community we live in. Certain factors have emerged as heightening HIV sexual risk behavior among women, and I will talk about them now. The first one is cocaine or crack use. Now, cocaine can make people more sexual. It can disinhibit people and give them poorer control over their behavior. And as it becomes addictive, which it does very rapidly, it can impel people to do almost anything to get the resources for their next dose of cocaine. And that can lead to risky behavior that is carried out without much thought. Similarly, if you are under the influence of other drugs or drink which disinhibit you, then you're also likely to have sex without really thinking it through and thinking through what you want to do and what you don't want to do. So sex under the influence of drugs or alcohol is also an important factor in HIV risk behavior. The type of sexual partnership in which you have sex is also very important in HIV sexual risk behavior. From early on in the epidemic, people were always very concerned about people with multiple partners, people with anonymous partners. And of course, this is very important because the more sexual encounters you have with more people, the more possible it is that you might acquire an infection from one of them. But sex between primary partners also poses special challenges. And this is why. If you are in a primary relationship with someone and you both assume that you are faithful and monogamous, it becomes very difficult, without hurting the other person's feelings or doubting that the other person trusts you, to use condoms all of a sudden in a primary relationship. So people have pinpointed primary relationships as posing special challenges for safer sex. Now, as we mentioned a little bit earlier, sometimes due to cocaine use, sometimes sadly due to widespread poverty, people feel they have to engage in survival sex or trade sex for drugs, shelter, or money in order to survive. And this can be another risk factor for HIV sexual risk behavior. I'm going to skip sociodemographics because we discussed it on the prior slide. Intimate partner violence is an important risk for HIV risk. Intimate partner violence is an important factor in HIV risk. If you are in a situation where your partner is violent or threatening or coercive about the kind of sex that you will have with him, then you are at greater risk for HIV risk behavior in that interaction. And finally, if you are in a high HIV seroprevalence area, then the likelihood that a sexual encounter might lead to HIV transmission, of course, is increased. So what are we to do? How should we respond? We need to carry out effective interventions, and in prior literature about women in HIV, some cardinal features have been identified. First of all, when interventions are gender specific, they are more likely to be effective. When interventions include comprehensive skill building, covering cognitive, behavioral, affective, and interpersonal skills, they are far more likely to have an effect on behavior than if they are only covering information only. And interventions need to be of a certain intensity. It has been shown that 4 or more sessions seems to be prerequisite to get an effect. What are the bases or theories driving these interventions? There are many different kinds of terms that are used to describe behavior theories. We will refer to the social cognitive learning theory, and this theory states that behavior is learned through the social processes of observing, of having behavior modeled, of rehearsing, and of getting feedback on how you're doing. And that's especially powerful within one's peer group. Empowerment theory states that individuals are empowered to action by several factors, and these include mastering a skill, acquiring peer support for it, and feeling that your behavior has some impact on yourself and on the world. These theories are the reason why our intervention features skills, features peer support in groups, and emphasizes the impactful and altruistic value of spreading the word about safer sex. Our intervention in overview. First of all, it's called Safer Skills Building, or SSB, and throughout this talk I will refer to it as SSB. It has several major features, and you see on the slide that it provides HIV and STD education, that it heightens HIV and STD risk assessment, that it teaches HIV and STD safer sex obstacle problem solving, that it coaches in condom use skill building and in negotiation skill building and in assertiveness training, and very importantly as well, that it advises women about how to assess risk of partner violence should they initiate safer sex, and how to plan for safety under all conditions. Now, SSB was born in 1993. The original SSB intervention was carried out successfully with an impact by El-Basal and Schilling at the Columbia University School of Social Work among methadone maintenance women. And here, in this trial that we will talk about, we have updated this intervention, and we have included not only women in methadone maintenance, who are very important to us, but also women who are in psychosocial outpatient treatment that delivers counseling without any medication. Now, what drives HIV sexual risk behavior? Let me mention some important components. Number one, what outcomes does a woman expect from her behavior? If she engages in unsafe sex, does she feel vulnerable to getting HIV or not? If she introduces a condom, does she feel she's going to get a positive or negative reaction from her partner? And if she does practice safer sex, will she gain the approval of others, like her peer group? Or will she feel proud of herself? The second factor is skill and self-efficacy. Does one acquire male and female condom skills? Does one learn how to eroticize safer sex or make it sexy? One has to gain negotiation and refusal skills around insisting on safer sex, and problem-solving skills for planning when there are obstacles in this very complex situation. Other factors that are important in safer sexual behavior is whether or not someone has goals that make safer sex important, like staying healthy and strong, maybe for one's children or for oneself. And I cannot emphasize enough making sure that one keeps the focus on that one does not incur the risk of partner violence from attempting safer sex, and making sure one has a safety plan in place. What are the techniques that we use? For skills building, we use information, instruction, and discussion. We model the behaviors that we're trying to promote. We rehearse them and get feedback from our peers in the group. And we role play and problem solve so that we can anticipate obstacles and have ways of overcoming them. Our SSB intervention is a 5-session intervention, and it's delivered over 2.5 weeks, twice a week. Each session is about an hour or so, maybe a bit longer, and each session has a comparable structure. At first, there's an intro and a check-in so that we make sure that everybody is focused when our session starts on the material at hand. We then handle the session content, and we move very importantly into interactive activities, which we discussed on the prior slide. And we close by giving a little bit of homework and also by what we call a worth affirmation. A note: Women on the Road to Health, or Worth, was the previous name of this intervention. And at the end of each session, women all spoke out loud together and stated the reasons why we were all worth it and why practicing safer sex was worth it. So we all exclaim our names and that we're worth it, and it's a very positive ritual. So quickly, I will run through the content of each session. In the first session, we state the intro and the purpose, and we lay out the counselor and the participant roles and rules. And this is very much like what all of you do in the counseling that you deliver. We have a warm-up so that people can kind of break the ice together. And in this warm-up, we all state why we want to take care of ourselves. We then discuss HIV information, and this covers how you get HIV, how you can prevent it, and how you can get treated for it. We do the same kind of thing about STDs, and we discuss HIV testing and counseling and where you can get it locally so that everybody knows how to do that. And we discuss living with HIV, including HIV treatment information. And this is very important because we may have women who are HIV positive or HIV negative in our groups. And in addition to that, we want to impart to women that at this time, happily, if women can receive appropriate treatment in a timely fashion, HIV is most often a chronic disease with a long lifespan ahead. Session 2 zeroes in on making HIV a little bit more of a personal topic. So we begin by an exercise in which we all tell stories about women each one of us has known or know of who's had HIV. And again, this is to make HIV more real. We call out the rationalizations that people commonly use to insist that HIV could just never happen to them. And then by way of challenging rationalizations, we use a vignette between two women, Jessie and Mathilde, who talk about Mathilde's having just met a man and wanting to have unsafe sex with him immediately, and about her statement that she really could never get HIV from him. Jessie's role is to challenge her on this, and both of their roles is to talk this out together. We then get a little more personal and talk about the rationalizations we ourselves have. We continue on and talk about the triggers for HIV and STD risk behavior, people, places, and things. And things can include both external things, like having access to drugs, and internal things, like feeling a certain way, like very stressed out or angry or frustrated or lonely, and more prone to perhaps engage in unsafer sexual practices for comfort. We then end this session by identifying our supports for taking care of ourselves. So we draw circles. We draw an inner circle of people we're very close to who would support our safer sex goals. We draw an intermediate circle for those that we are acquaintances of, and we draw a larger circle for those people that we don't know that well, but maybe they have been positive about practicing safer sex. They've been supportive of that. In session 3, we focus in on developing safer sex skills. First of all, we use a stoplight exercise, which I'll show you, to identify those behaviors that are high risk, medium risk, and virtually no risk. We use male and female genital models to practice proper male condom use and proper female condom use. We have a call out about how to make safer sex sexy or erotic. And then we introduce a method of problem solving, which I will describe, called SODAS, which helps us talk to ourselves in tough risk situations and also helps us to negotiate safer sex. In session 4, we zero in on negotiation. We first identify the potential obstacles to safer sex in sexual situations. We then practice safer sex negotiation. First, we learn the basics of negotiation and refusal. Then the counselors demonstrate it, and then we discuss it. After this, participants pair up and they take turns, each one being the woman and then being the man in vignettes that we supply, and navigating through temptation situations. Finally, we go through how to assess the risk of partner abuse from introducing safer sex, and we go through making safety plans. In session 5, we end with a graduation, refreshments, certificates, and celebrating the good work that we've done together. And we also recognize that even when a woman feels that she's ready for safer sex or has even initiated safer sex, that there could be a time when she has a slip. And just like we do in treating substance abuse, we work hard to try to help women recognize a temporary slip when they engage in one, identify it as such, put the brakes on it, and go back to the safer sex behavior that they were aiming for. So I promised you I'd show you the stoplight exercise. You can see here that a green light means go, that there's no risk, no exchange of bodily fluids. A yellow light means caution, that there's low risk and little chance or relatively little chance of exchange of bodily fluids. And a red light means stop, because it's high risk and it shouldn't be done if you can at all help it. What are some examples? A red light would be vaginal sex without a condom, a yellow light, vaginal sex with a condom, and a green light, massaging or rubbing each other's bodies without exchange of bodily fluids. I also promised you that I'd talk about the SODAS model. So this is a problem-solving model which starts with S for stop and define the problem and your goal. O for define your options and think about the outcomes of each of these options. D for decide. So you want to decide which option you're going to use. A for action. So you're going to act on your decision. And S for self-praise in going through this process. Now I'm going to put SODAS to work in a real situation. And I'm going to move on to another slide where it's going to be much clearer. Okay, so here is a vignette, and in this vignette, Latricia just met this guy James at this party. She kind of knew him before. They go back to James's house. Latricia is feeling a little uncomfortable, but she's horny, and James is coming on to her, and he is looking real good. She wants to have sex with him, but she will only have safer sex because she doesn't want to get anything. So our SODAS process starts with what is Latricia's problem. And this is the stop and identify the problem and the goal. And those are that she wants to have sex with him, but she will only have safer sex, and she is feeling unsure of herself and uncomfortable with James. Now on this next slide, you'll see different options that Latricia has. And along with this, I'm going to discuss the possible outcomes of each of these options. So one is that she can negotiate with him to use a condom. Now, there are different kinds of outcomes that can be expected of that. One is that it'll work out okay. Another is that since she's feeling unsure of herself, she might not be able to hold up her bottom line of having safer sex, and he might be able to talk her out of it. Another option, she can slip the condom on when she gives him head. This actually might work best. She can avoid having to ask him directly. He may find this sexy, and he won't be able to talk her out of it. Another is that she can have an alternative to intercourse that is safe, like giving him a hand job. This may result in his finding it sexy, and here she also can avoid having to ask him directly. She just hopes that this is good enough for him. Another is that she can refuse to have any sex. She can do this directly by saying no, or indirectly by making an excuse. Now this surely would protect her, but her goal of having sex would not be achieved. So that's a little bit of a look at how SODAS works. Now let me focus for a moment on this very important aspect of this intervention, which is identifying the potential for partner abuse in your situation or in a woman's situation and making a safety plan for it. So we discuss with women what are likely factors that place them at risk for partner abuse. So for instance, we talk about whether there has been a history of violence or a current history of violence with their partner. We talk about whether their partner is high or drunk or under the influence of something that would make him impulsive and less able to control himself. And so these are very important conditions that would put up a red flag for the woman about whether or not this would be the right time to introduce safer sex. Of course, we want to encourage women to introduce safer sex, but only under safe conditions. Secondly, it's very important to map out a safety plan. So this includes things like gathering key phone numbers, the local domestic violence hotline, the local shelter, and a close friend or associate or someone who you can call at any time who would let you into where they live on no notice, or who could call the police or somebody else who could help protect you if you were in danger. This also involves having a place where you hide a small amount of money for travel for yourself and your children to the shelter or the nearby place that you would go in an emergency, your social security card, maybe some additional clothes for you and your child, so that you basically, at a moment's notice or less, can leave the risky situation. Now, I'm not going to spend a lot of time on this slide. I'm just going to emphasize to you that our intervention was done in 12 community-based treatment programs across the country. Half of them were methadone maintenance programs, and half of them were psychosocial treatment programs. The intervention was carried out and supervised by frontline counselors and supervisors. The intervention is easy to learn with training and easy to integrate into substance abuse treatment counseling. This is if you train, and if after you're trained you establish that you've got the skills that you need to conduct the intervention as it's meant to be conducted. And this is what we call certification. And I won't go into the details. I will only say that it's part of the package of training, and it's really easily done with focus on the training. And I'm going to emphasize here that in addition to the particular skills of SSB, which we've discussed, the skills that you already have, I'm sure, so well for attending and listening, expressing, responding, for guiding group interaction, for involving group members, for giving reinforcement and positive feedback, for synthesizing all the communications that take place, for giving support and selective advice, suggestion, and instructions. These are skills for running any group that you need to marshal in running these groups. So let's go to the reason why we're talking about this particular intervention today, and that is because in a randomized clinical trial, we established that the intervention was effective in reducing unprotected sexual occasions, or USOs. And let me tell you just a bit about the trial so you'll believe me. So this is a chart of the different steps involved in the trial. First, at baseline, women are assessed for their eligibility and also to understand their starting point in unprotected sexual occasions and other things of interest. And we'll discuss eligibility criteria in a moment. And then women are randomized. Now, what are they randomized to? In a randomized clinical trial, you've got to have the intervention or the treatment that you believe is important and powerful, and you have to have a comparison condition that can be compared to the active intervention condition. In our study, we landed on HIV education, a one-session group education session, as our comparison condition. Why? Because we did some preliminary work and we discovered that the very most common way that people received HIV education in substance abuse treatment programs was through a one-session HIV education group. So women were randomized either to SSB, which again is a 5-session, twice weekly for 3 weeks, safer sex skills building intervention, and the comparison condition was one-session HIV education. Now, in order to discover whether there is an effect from these interventions and what the level of that effect is and whether the effect is different for HE and SSB, you must do follow-up assessments. So we had a follow-up assessment immediately after the intervention was over. We had another at 3 months, and we had another one at 6 months. The one at 6 months, where a considerable amount of time has passed in which to see the effect of the intervention is our primary outcome assessment point. Now, how were women eligible for this study? They had to be participants in a community treatment program for drug treatment. They had to have had unprotected vaginal or anal sex in the past 6 months, and we'll be referring to this as USO, or unprotected sexual occasion. They had to be willing, and they had to understand and speak English. Why weren't women included? If they were immediately planning pregnancy, then we felt that the goal of safer sex and protection would create a conflict for them. And if they were so cognitively impaired that they couldn't participate in a group, we did not include them. Our primary outcome, as I mentioned, was unprotected sexual occasions. Please note that we used the prior 3 months to each assessment, including the baseline, as our time period for counting unprotected sexual occasions. We also had other outcomes, and principally among them was the proportion of occasions of sex in which the woman was also using drugs or alcohol, the woman's perceived self-efficacy to carry out safer sex, whether she was carrying condoms or not, and her gender role beliefs. Did they move from being very traditional woman as passive gender role beliefs, or did they change to something more flexible? This chart shows the movement through the different stages of the study, so we'll spend a little time on this. Now, as I mentioned, we worked in 12 terrific sites across the country, and half of our sites were methadone maintenance, and another half of them were psychosocial treatment sites. Altogether, we screened 824 women for eligibility, and of those, we randomized 515. What happened to the other 309? Most of those 309 just didn't meet the inclusion criteria. Happily, only a small number, 17, refused to participate, and 72 had another practical reason why they couldn't participate, or even participate in the drug treatment program. Of the 250 women in SSB, 154 received at least one SSB session, and 108 received at least 3 of 5 sessions. Receiving 3 or more sessions was our definition of being a treatment completer. Among the 265 women in HE, 165 actually received the 1 session of HIV education. Now let's look at the bottom row to look at our follow-up rates. The greatest drop-off in both treatment conditions occurred at 3-month follow-up. In the SSB arm, we followed 62% of the women. In the HE arm, we followed 70% of the women. There was negligible dropout between 3 months and 6 months. At 6-month follow-up, 62% of the SSB women were followed up, and of the 265 HE women, 67% were followed up. This slide answers the question, who was in the intervention, and were the women in the 2 intervention conditions comparable? Happily, on this slide, you can see that on every single important variable, the 2 intervention conditions were comparable. So, about half of the women were either younger than or 40 years old. About 2/3 of the women were white. about a quarter of them were black, less than 10% were Latina, and less than 10 were either of mixed ethnicity or of another ethnicity. Now, an important variable was what we called monogamy. This meant that a woman told us that she only had sex with a person she called her main, steady, or primary male partner. So you can see that about half of the sample was monogamous by this definition and half weren't. Now you remember that we included women from both methadone maintenance and psychosocial outpatient treatment, and the sample was about split between these two types of treatment programs. As far as education was concerned, a little less than a third of the women had less than a high school education, a little more than a third had just a high school education, and about a third had more than a high school education. As far as the starting point of unprotected sexual occasions were concerned, the two intervention conditions both had about 18 or 19 unprotected sexual occasions in the past 3 months. Here is a way of looking at the attendance in the intervention conditions. And you can see here, if you look at the column under SSB that says, I'm going to start again. This slide shows the attendance at the interventions. And if you look at the columns expressing attending 3, 4, and 5 sessions under SSB, I'm going to start again. This slide shows the rates of attendance at the interventions. And if under SSB you look at the column that says greater than equal to 3, that is the percentage of the SSB sample who were completers. That is, they attended at least 3 of the 5 sessions. The completion rate was 43%. We had hoped for more, but this is not very different from the completion rate of treatment in a lot of substance abuse treatment. On the HIV education side, you'll see that under the 1 column, about 62, in the HIV education column, you'll see that under the 1 column, about 62% of the women attended HIV education. This slide shows that when people who are frontline counselors received our training and certification, that they continued to adhere to the treatment manual, to the intervention as intended, at a 78% adherence rate. This slide shows the statistical analysis that we used. And the important thing here, without getting too technical, is that we used a mixed effect model that allowed us to adjust for several factors that we thought would be important to adjust for. And I think I won't really go on any more about this technical aspect of things. What I'd like to show you here is our results. And this table shows you at the very bottom line that there is a significant time by treatment effect for the intervention. What does this mean? This line expresses the fact that the 2 different intervention conditions differed in the change that took place over time in unprotected sexual occasions. And what we want to see is that the F value is large at 67.18, and most importantly that the P value, which expresses the probability of getting effects by chance, is very low, at less than 0.001. Now let me show you what this really means. So this is a graph, It shows that the pink line is SSB and the blue line is HE. Now, both the pink line and the blue line decrease in their values from baseline to 3-month follow-up. And this is a happy observation that even when just giving HIV education, there was a decline in the mean number of unprotected sexual occasions for the HE group and for the SSB group alike. Now, what happens after that is that in the SSB group, that decline is held. In the HE group, that decline is not held. In fact, there is an increase in the number of unprotected sexual occasions from 3-month follow-up to 6-month follow-up for the HE arm. So, even though there was an effect from both interventions which was not different from one another at 3 months follow-up, it took the comprehensive skills building of SSB to hold that decrease at 6-month follow-up and even bring it down a little more. And what we see on this slide is that at 6 months, the SSB group had an average of 13.96 unprotected sexual occasions in the prior 3 months, as compared to 24.14 in the HIV education group. Now, I'll show you a similar slide to discuss the effects of the intervention when we consider only the completers. And you can see on this very busy slide that at the bottom, where there is a term called treatment by time by completion, we are also seeing a very low, less than 0.001 value of change happening by chance and of difference happening by chance in this analysis. Let me show you what these results are. So among the completers, we see the blue line is the HE line and the pink line the SSB line. The blue line and the pink line both decline at 3 months. But at 6 months, once again, the blue line goes up. So the unprotected sexual occasions are increasing, whereas the pink line holds or even goes down a little bit. The difference between the change observed for the SSB group as compared to the HE group in the completer sample only was larger than the significant difference obtained in the total sample. So at 6 months, the SSB group had a mean of 10.52 unprotected sexual occasions per past 3 months, whereas this value for the HE group was 26.38. Now I'd like to summarize and end with some implications of this work. I think very importantly, frontline counselors within the context of substance abuse treatment can deliver a feasible and effective 5-session safer sex building intervention in groups with women that does produce a significant change as compared to standard of care HIV education. What are the implications of this? The implications is that it's really imperative that we combine substance abuse treatment with HIV prevention interventions. We also learn from delivering comprehensive skills building that included condom use for female-controlled condoms and male condoms, and that included negotiation skills and problem solving, that we've got to change social and cultural norms regarding sexual behavior, and empower women to make more choices, to be more thoughtful, to be more deliberate, and to be more expressive in their sexual relationships, and that we have to advance female-controlled methods. I want to thank you so very much for coming on this journey with me, and I hope that I have really emphasized how capable and powerful you as counselors can be in HIV prevention. Thank you.